Hello, everyone. We'll give a few minutes, just maybe one or two. Welcome. Scoping out our list here. Excellent. All right, 1 minute's enough. Let's go. So, welcome to our Pocus in the Home, the Next Frontier talk. My name is Renee Dversdal. I'm not doing this background to make you jealous. I'm literally on vacation. That's how much of a Pocus fiend I am. So, this was the best timing, and I thought, let's do it. I love Pocus so much, I'll talk about it anywhere. So, I am the Chief Medical Officer at Vave Health, and I also am Professor of Medicine at OHSU unaffiliated roles here. I'm here in my Vave hat, and I'm so excited to be here with Dr. Daniel Kim. So henceforth, I will call him Dan, and he will call me Renee. We're going to be casual, but I want to just tell you a little bit about him. So Dan did his undergrad, both BS and MD at University of Michigan, and then commenced on many years of postgraduate education at Penn. So very cool because he did his internal medicine residency and then a POCUS fellowship with the fabulous EM and IM POCUS teams there, and then geriatric fellowship after that. So he's able to learn and apply all of those wonderful skills in geriatrics. He's had a clinical role at the Philly VA ever since. And then in 2021, took over as the community living physician at the center, the geriatric center in Wilmington, at the Wilmington VA, rather. And he's also, I need to learn more about this, but we'll save this for a different time, the co-director of SLEX, which is SimLearn Innovation Center for Education. So I have a simulation role at my uni. We'd love to hear more about that, but we'll focus on POCUS for the day. Also has had leadership roles in POCUS development and education at Lewis Katz School of Medicine at Temple. And also, as you can see here, is an adjunct assistant professor at Rowan Virtua School of Osteopathic Medicine. Uh, he's taught with the ACP national courses, POCUS foundational skills for home care provider with AAHCM at so that was a workshop at the national meeting. And then also has a couple of very cool publications, including geriatrics oriented POCUS curriculum and fellowship. And then even cooler, a citywide POCUS curriculum for geriatric fellows. And then that work has also led to presentations leading up to a culmination of one about a nationwide POCUS curriculum for geriatric fellows at the American Geriatric Society. So there's no better expert in this field. So I'm really excited that Dan can join us. And we will go ahead and kick it off here. So our objectives, we wanted to make sure y'all can do a couple of things when you're done here. Focus is a huge topic. You could spend many, many, many days learning, or days, years, whatever. But we just want to give you some tools if you were thinking about applying this in the home care setting. Uh, as I mentioned, Dan is the expert. I've done a hospital at home paracentesis in the home and just a couple here and there, but we're real excited to hear his cases. So we're going to define POCUS. We're going to describe enablers and benefits of using POCUS in home care. We're going to talk about some of the technical requirements, and then we're going to go through some clinical use cases in which POCUS can augment home care. As luck would have it, the people are literally on top of the palm tree trimming it right now. So we're going to see how good my earbuds are. I think they're going to be okay, but if not, please forgive me. Someone can, well, yeah, you will all live together. This will be fun and adventurous. So hopefully the background will make it worthwhile. Okay, so let's go ahead and kick it on to the next part here. So what is point of care ultrasound? Obviously, none of you, well, maybe you are, but probably the majority of our audience are not sonographers or radiologists. So I love this graphic from NephroPOCUS, Dr. Abhilash Karatala. His website is amazing as well. So the secret sauce of POCUS is you're the clinician at the bedside, face to face, or the bedside, the home, out in the field, wherever, but you have a clinical question. So his example, he's a nephrologist, is does this patient have hydronephrosis? Maybe they presented with acute kidney injury. So no POCUS, that's where our sonographers and radiologists come in. I'm going to place an order. A sonographer is going to acquire the images. A radiologist is going to interpret those images, and then I'm going to get a report later that I will clinically integrate. Versus POCUS, I'm the clinician at the bedside. I'm going to put on my sonographer hat, acquire those images, put on my radiologist hat, and I'm not replacing a radiologist. I'm going to have some pattern recognition, some basic yes, no to interpret it, and then I'm going to clinically integrate it in real time. So that's our secret sauce of POCUS, clinician face to face. And it's not comprehensive ultrasound. This is Dr. Karotala, and he didn't do this on purpose, he told me, but you can see the Vave up in his little top left, that top pocket, versus a kind of more standard radiology or comprehensive ultrasound machine. So notice all the buttons, there's calc packages, there's very expensive fancy probes and things. So we're going to more focused yes, no questions to guide my differential diagnosis, to guide my treatment, to guide my procedures. For instance, I'm not great at the gallbladder, but I can find the gallbladder and I can say there's a big stone or there's not. If I wanted to look at the common bile duct, for me personally, I know my level of skill. I would order a comprehensive ultrasound and a sonographer would do all of those things. So POCUS can be as focused or as complicated as your training in your skill. For me, I love to keep it very focused, binary, yes, no, guiding. So we'll kick it to our next slide here. You can do this anywhere. These are just a few of my favorite photos. The bottom right, Chris Fox at University of California in Irvine does their like image reviews out on a boat, on his boat. And so we just were playing around with the med students and they were scanning themselves out on the boat. The middle's in Guyana teaching some paramedics there. Pre-hospital POCUS is growing immensely. And then just another one of our docs just with it in the pocket there. And I'm going to kick it off now. You finally get to hear the amazing Dr. Daniel Kim. So welcome and thank you. I'll go on mute for a bit here.
Thank you so much, Renee. Can you all hear me okay? And so why should we as home providers and geriatricians care about ultrasound? I'm going to talk about one of the biggest reasons why all of us should care is really the limitations of our physical examination. And for me, this came to light when I was a resident on the cardiology service, and the cardiology attending and the cardiology fellow were arguing with one another about where they thought the jugular venous pulse was on this patient's neck. And I, for one, could not find the JVP at all. And I remember just being flabbergasted at how two much more experienced clinicians than I was couldn't agree on what I thought to be a simple physical exam maneuver. And this is what led me to dive into the evidence behind our examination, physical examination. And when you look at common conditions that affect older adults, like congestive heart failure, pneumonia, effusions, DVTs, soft tissue infections, retention, and ascites, our ability to rule in these conditions by our physical exam alone, the likelihood ratio ranges from 1 to about 5, meaning that it's really not enough to help move the needle at arriving at the right diagnosis. But when you add in point of care ultrasound to that, we're able to increase our confidence in ruling in these conditions by 2 to sometimes 4 or 5 folds. And the same goes for ruling out these same conditions. Our physical exam actually fares even worse, and a lot of times is actually pretty useless. But when you add in ultrasound, we're able to increase our ability to rule out these conditions in our patients. And this is why many physicians consider point of care ultrasound to be a fifth pillar to the bedside physical examination, that we should not only be inspecting, palpating, percussing, and auscultating our patients, but that we should also be insunating our patients at the bedside. And we all know that ultrasound is incredibly safe. There's absolutely no radiation, and we're able to minimize that for our patients. And we know that for our patients who are homebound, our patients who have a hard time making it to the hospital to get a radiology image done or to get labs done, that for our patients, these patients have delays in diagnosis and treatment, and this leads to increased morbidity and mortality for our patient population. And this is part of the reason why I argue that our homebound patients are probably one of the most ideal for point of care ultrasound because many of our patients have dementia. And when we meet them, they're not able to tell us in detail how their symptoms have changed or progressed. So you're working with limited information from the onset, which can be challenging. Many of our patients are also frail. And we know that frail older adults don't have typical presentations for common conditions. When our patients have pneumonia, or acute heart failure, they're not going to have a fever. They're not going to have dyspnea exertion or apnea PND. They're going to present to us delirious. And thankfully, many of these conditions that affect the older adults are amenable to be diagnosed or ruled out by POCUS, as I've mentioned before. And finally, my favorite point of care ultrasound is incredibly patient centered. Instead of sending the patient to the hospital, to the ER to get diagnostics done, we're able to meet them in the home, whether it's in their bed, on their sofa, whether it's in their wheelchair. And patients truly appreciate that. And doing POCUS for my geriatric patients have really reinvigorated my love for clinical medicine. And one thing to remember and to know is that POCUS does not require a physician. Many studies have shown that other providers that are essential parts of our home care team, such as nurse practitioners, physician assistants, can be trained to effectively use POCUS in the home. So now I'm going to kick it back to Renee.
Okay, welcome. We've moved on to a different tree. So if you heard that before, we'll be good now, hopefully. So we just wanted to, again, Dan is much more of an expert, but I have ultrasounded several times in the home, including a paracentesis. So I just wanted to talk about a couple of technical requirements or things that make your life easier. So go ahead and hit the next slide for me, please. Thank you. So as we mentioned, the portability, or we talked about patient-centeredness, but portability is key. ChatGPT helped me make these images. And so I had to tell it, I said, please make it look like the patient is on the second floor. So for home, for instance, hospital at home, OHSU has hospital at home and medical home is our provider. And so they talk about they have to go up. Certain portable radiology groups will only do it if it's on the first floor. I actually haven't explicitly asked them who we use at our site, but things like getting up the stairs and stuff, just little things like that you really wouldn't think of can make a really big difference. And I tried to ask again, ChatGPT to make this kind of a cluttered bedside. So even in the hospital, getting the cart there can be tough, but hospital beds are not made for the average patient's living room or bedroom, for instance. And so portability really, you have to get that machine to your patient's bedside. So that's one major thing. And then the cords here. So, and if you click it one more time, this other one will pop up. Normally I don't add animations, but there we go. So people tend to, so a lot of things we have these days are cordless. And if we're in a very crowded environment, the cord, let's say somebody's holding the viewing device for you, you have to make sure you're within that cord length. And so I've done a lot of teaching in skilled nursing facilities. I'm with a partner of ours. And it's amazing how much a cord can keep you from getting to your patient or getting to the area that you want. So, of course, we have this is, after all, a Vave sponsored webinar. So cords can be a hassle. Some people work just fine with them, but a lot of times the cordless is a benefit. And we'll kick it to our next slide. Dan is going to talk to us about a bunch of his own use cases. We're going to have a new website and a new launch webinar very shortly for what I call the unicorn, which is our universal probe. So what we have is a combination of a phased probe with a linear probe, or it's all one probe, it's different sectors. This is not an engineering, so I shouldn't even go into the details. We'll talk about that in a different webinar. But you can do basically whole body imaging, and Dan's cases are going to go through multiple uses that include both a deeper sector image and a shallower linear image. And so, yeah, we're excited to have something that works perfectly for home care cases. Kick it to the next one here. This is really important. So I believe in high value care. Uh, Other times we have to get our billing with CPT codes. To one of the people I know says at the university says no margin, no mission. So there's a couple of reasons you have to be able to store and share. Number one, if you want to do any billing, whole separate webinar, but you have to be able to archive those images. And then sharing can be very important, especially when we're talking about maybe it's a home nurse assessing a bladder, or it's a doesn't matter. It could be an MD who's just like, hey, I'm not sure about this, and they want to phone a friend. So being able to share the images to get feedback. Also, again, a whole different webinar on archival, quality assurance, feedback, etc. But it really is key that you have the ability to store and share the images. Kick it to the next one, especially as our patients and healthcare systems are under more and more stress, money matters. So when you're looking at devices, you really need to take into account the total like cost of ownership. So maybe you can buy a device for a flat amount, but it's $500 a year to be able to use the software or the storage. Maybe it's a 1 year warranty, but you need to have it last 3, and you're going to have to pay for each of those. So definitely take into account your total cost of ownership when you're thinking about these things. And so that's something that we're very proud of. That we have a very simple model there. You buy it and you own it, use it as long as you want, and you never pay anything more. So when we're thinking about POCUS, again, education is an entirely different webinar we could do, or course, workshop. But I like to talk about the 3 POCUS pillars. So as you're thinking about building up your capacity, adding a new clinical service, or adding something onto what you already do, you want to think about the skill, the technical, tactile skill of image acquisition. Again, that's like your sonographer hat. Your image interpretation. So that's going to be our pattern recognition, normal, abnormal, and then our clinical integration. So make sure if you're trying to train up or add this, that we think about each of those pillars as you're developing your skills, because you have to be able to perform each of these to be competent in using ultrasound. So yeah, these are the things to think about as you're thinking about adding or building. But now we're going to go into the good stuff, the really good stuff. Dan's going to share with us cases of what to ultrasound in the home.
Thanks, Renee. And so, as Renee has mentioned, POCUS is helpful for help answering numerous number of clinical questions, and it's really good for very focused questions that have come up after you've done your history and your physical examination. And questions like, does my patient with dyspnea have heart failure or pneumonia? Does my patient with an acute kidney injury have urinary tension or hydronephrosis? And does my patient with swelling of the legs have a DVT? And so I'm going to share with you a couple of actual clinical cases of patients I've taken care of in the home that highlight this. And so my first patient is a 70-year-old female, homebound with morbid obesity, heart failure, asthma, chronic edema of the legs, who called into our home-based care office with a couple days of shortness of breath. So I went in to see her in the home, and it was my first time meeting her. And these were her actual legs when I arrived. And you can tell right off the bat that this was going to be a very challenging examination, and it was. She was sedentary at baseline, couldn't really tell me additional details about her symptoms. I tried to do a physical examination, could not find her JVP. She could not sit up for me from a recliner, and so I had to listen to her lungs anteriorly, and I could barely make out breath sounds. And then her legs had chronic swelling, and she couldn't tell me if it was worse than usual. And so here's a scenario that's very, very common where the history is limited, your exam is limited, and your differential remains the same and has not been narrowed even after you've performed all these things. And just to highlight our ability to find the JVP accurately as clinicians, Unfortunately, many studies have shown that residents and even attendings are not great at correctly identifying the jugular venous pulse. Now, thankfully, with point of care ultrasound, all of us can identify the jugular venous pulse 100% of the time, regardless of body habitus. And it actually correlates closer to the central venous pressure than our physical examination does. And so I took my probe, put it on the right side of her neck, and I identified her internal jugular vein sitting on top of the carotid artery. And she was already reclined at about a 30 to 45-degree angle, which was convenient. And I was at the level of the clavicle looking down. And you can see that already her internal jugular vein was collapsed at the level of her clavicle. And so I knew her jugular venous pulse was low to normal. And I also want to highlight the sternocleidomastoid muscle we see right underneath the probe and see how thick that muscle was, and that there was no way that any of us would have been able to see the pulsations on her neck. And then I scanned her anterior lungs with the probe. And what I saw were these horizontal A lines, which are simply an artifact of the pleura itself, which we can see in normal air-filled lungs. There was no evidence of pulmonary edema, consolidations, or effusions. And so in a span of a couple of minutes, I knew that my patient's JVP was low to normal and that her lungs were clear. And I ended up treating her for an asthma exacerbation with steroids and nebs, and her symptoms improved. Now, how hard is it to find the JVP on ultrasound? All of us can easily learn. You simply place a probe in the sternocleidomastoid triangle with the patient reclined, and you identify the IJ that usually sits on top of the carotid. And here we see the thyroid gland right adjacent to the carotid. And once you've identified the internal jugular vein, you want to slide up the neck until you see the point where the walls of the IJ collapse. And that point on the neck correlates to the jugular venous pulse. And if you were to simply rotate the probe 90 degrees to get the long axis of these images, the vessels would appear like tubes instead of circles. And the point where the walls of the IJ taper and come together, again, correlate to the JVP on the patient's neck. So my second case is similar. This was an 86-year-old gentleman on hospice with end-stage COPD, on 4 or 5 liters of nasal cannula at baseline, had heart failure, had chronic edema, was calling into our office with shortness of breath. And you can see that a lot of my patients have same comorbidities, and I'm sure all your patients do as well. My home-based care colleagues decided to diurese him empirically, increase the Lasix twice a day for about a week. And they checked labs at the end of the week. And unfortunately, the creatinine had bumped slightly, and this patient's symptoms did not improve at all. And they were at a crossroads between whether or not continuing diuresis and potentially risking renal failure, stopping diuresis and treating for a COPD flare with steroids. They were even considering sending this patient to the ER for additional diagnostics. But thankfully, they had me and they said, Daniel, can you gather more data with your ultrasound in his home? And I said, of course I can. So I went to his home, and when I scanned his lungs interiorly, instead of the horizontal A lines we saw before, now we see these vertical lines emanating from the pleura, extending all the way down the screen. And these are called B lines, and B lines occur in the lung when you have increased density of the lung. And in this case, it's pulmonary edema. And then I scanned the base of the lungs. And above the liver, above the diaphragm, we see a layer of an effusion surrounding an atelectatic lung. And then I scanned his JVP and find that it was elevated. And I was able to find that, or make the assumption that a component of this patient's shortness of breath was still driven by volume. And this patient still had significant edema in the lungs that we could continue diuresing, which we did. And I wanted to highlight for all of us to know that lung ultrasound is superior to chest x-rays for diagnosing heart failure, pneumonia, pneumothoraces. So when we have the opportunity, we should always be ultrasounding and not ordering x-rays. And when we focus on congestive heart failure and diagnosing this condition, And you look at common signs and symptoms like orthopnea, JVD, edema, rales, the likelihood ratios are all close to one, meaning that they're pretty much not helpful. If you can get an X-ray, which we can in the home, and it's positive, it's helpful, but it's not sensitive. And an NT-proBNP can help rule out heart failure, but we know that there are limitations to that as well. However, lung ultrasound and the vertical B lines that we see in lung ultrasound have a likelihood ratio that approaches 10 for ruling in and 0.06 for ruling out. And this is really approaching what we consider to be a gold standard diagnostic test. And because of that, studies have shown that when we use lung ultrasound, we're able to diagnose heart failure quicker, providing appropriate treatment for these patients faster. And when we use ultrasound to guide our diuretic therapy, our Lasix management, it actually improves patient outcomes like ER visits, hospitalizations, and even mortality. And that's what we really care about. And this is why the use of POCUS in evaluating the lungs for older adults with undifferentiated dyspnea is actually a clinical guideline that's recognized by national associations like the ACP here. My third case is a similar case, a 77-year-old lady who actually had a hip fracture, was hospitalized, had a COPD flare, was treated with steroids. And then on the day of discharge, she had very mild hypoxia, citing 90% on room air. They got an X-ray, showed some mild pulmonary edema, and they thought she was stable enough to discharge her home on a short course of diuretics. And so she was not on diuretics at baseline, so they sent her home. And I got to see her in the home a couple of days later. And the question in my mind when I met her was, when do I stop diuretics in this patient? And so I scanned her lungs the first time I met her. And again, we're seeing these vertical B lines extending from the pleura all the way down, all throughout her lung fields. And so I knew right away that she still had significant pulmonary edema and could benefit from further diuresis. And after about 5 days, I came back and rescanned her lungs. And now we see the disappearance of the vertical B lines and the reappearance of the horizontal A lines that are, again, an artifact of the pleura in normal air-filled lungs. And so by ultrasounding my patient's lungs, I knew that she had minimal pulmonary edema and that it was the right time to stop the diuretics. And as I was feeling really good about this patient about to leave the house, she said, "Oh, Dr. Kim, by the way, I did notice that my left leg was a little bit more swollen than the other. And that leg was the leg she had her hip fracture on. And she said she was worried about a DVT. She forgot to mention it, and she was wondering if she needed to go to the ER. And in most cases, this patient probably would have been sent to the emergency room through an ambulance to get urgent Dopplers done. But thankfully, I had my ultrasound device, and I said, you know what? I will take a look at it for you right now. And so I took my probe, put it near her inguinal ligament, and identified the common femoral vein here next to the common femoral artery. And I pressed down on the vein until it completely collapsed, indicating that there was no clot in this area. And then I slid down her leg, identified the femoral vein, and again, compressed down on this vein, showing complete collapsibility. And then I scanned her popliteal vein and the popliteal fossa, which is sitting on top of the artery. And again, you see me compressing down, showing complete collapsibility of the popliteal vein, indicating no clot. And I knew from many studies that have shown that when you're able to exclude a clot in these three locations of the leg, you're able to exclude a DVT in the entire leg with very good sensitivity. And so for my patient, I knew that with confidence that this patient likely did not have a DVT in that leg, and we were able to avoid sending her to the emergency room. What does a DVT look like? Here's an example of a DVT in the common femoral vein. You can see this is the common femoral artery. You can see that we're pressing down on the subcutaneous tissue and the vein is not collapsing. Here's an example of a clot in the femoral vein next to the femoral artery. Again, here we're compressing down enough to compress the artery, and yet the vein remains uncompressible. We can even see echogenic material within the lumen here, indicating the presence of a clot. And then here is a popliteal vein on top of an artery. And again, we're compressing down on the artery is compressing, and yet the vein on top is not collapsible. And lastly, I'm going to focus on the bladder, my favorite. Um, this is a 106-year-old female who was on home hospice with moderate to severe dementia, had recurring constipation issues that led to recurring UTIs and frequent visits to the emergency room. And this patient had just came back from the ER again due to a UTI, and they had scanned her belly with a CAT scan. They found that she had a lot of stool that was leading to urinary retention, and they discharged her home on laxatives and antibiotics. And I was seeing her home about a week later to see how she was doing. And the question that we had was, as her constipation had improved, we were wondering if she was still retaining a significant amount of urine. And this was important because we had been suggesting to the family and the daughter of placing a Foley in the mother just for comfort and to improve her quality of end of life. And the family had been resistant this entire time because they were afraid of the risks associated with a Foley. And so when I went to this patient's home, decided to scan her bladder in front of the family and the daughter, and I placed a probe below the umbilicus and scanned through the entire bladder in the long and short axis. And by measuring the length, the width, and the height, and multiplying that by a coefficient of 0.75, I was able to accurately determine the bladder volume for this patient, and it was significantly elevated, greater than 700 cc's of urine. And the daughter was there standing next to me watching these scans. And as I showed her how big her bladder was, and it became very clear to both of us that this distended bladder was probably causing discomfort in her mom, was probably leading to recurrent UTIs, and that a Foley will probably be more beneficial for this patient. And this is an example of how POCUS helped actually advance goals of care for this patient and improve her end of life quality. Studies have shown that using ultrasound to measure bladder volumes are equivalent to catheterizations, and they're actually superior to bladder scanners that we often use in the hospital or in nursing homes because bladder scanners can often spit out inaccurate numbers. And bladder ultrasound can actually be helpful for other things, particularly for patients who have a chronic Foley and you get called about decreased urine output. You can quickly scan the bladder of a patient to see whether or not there's an obstruction. And here we're seeing a distended bladder full of urine surrounded by a Foley balloon. So we're scanning through the bladder. Oh, yep, there we go. So just to
I
show you
swapped
guys
out a
again.
few of Dr. Kim's
Yeah,
videos. Sorry, Dan. This was actually just this was my father-in-law. So he had a Foley place while waiting a turp, and he calls me at like 4:30 on a holiday, the day before holiday, and says like I have nothing's come out of my Foley in 6 hours. And I'm like, this is not going to ruin the whole holiday. Kaiser told him to go to the ER. And I was like, absolutely not. So you can see this is 2016 on this. This is an old school handheld. Oh, sorry, you can see the company. Oops. But old school handheld. And I could see, I saw it was clogged, booked it to the medical supply store, got sterile saline, went home, flushed it, 600 cc's comes out. And so, yeah, I swapped it because my father-in-law gave me permission to share that story. But that was my first exposure to home ultrasound back in 2016. And then this one here, I threw in a couple extras at the end. So this one will you do me a favor and play it one more time? I'm sorry I didn't get the loop on there. So this is a classic example. If anyone's ever had the Foley, a bladder scanner say that there's like 500 cc's of urine, and then they straight cath and nothing comes out. That happens to me quite frequently as a hospitalist. So it looks like there's bladder. And then you scan and you realize it's not bladder. And there's a little Foley balloon right there and a decompressed bladder. So this is an example of ascites with a decompressed bladder with a Foley balloon in the middle of it. And so I will always, always, always love looking at the real bladder, not taking something for granted that because what those bladder scanners can pick up is they pick up how much fluid to the bowels and they think that's the back wall of the bladder. So that's a decompressed Foley in ascites. Oh, and I threw in this one too. I love the bladder so much. So this was a patient who was transferred to the hospital. So I'm sorry, but this could happen at home too. So you might see this at home. So this is just another example of a Foley balloon. And then you're like, what's that schmutzy stuff in the bladder? And that's actually a hematoma. And so we knew in that case, this might happen at home. And you might be like, okay, that patient actually needs bladder irrigation. They need a continuous bladder irrigation. So that might be, I think it's like, what can you do to keep people where they are, but then also appropriately know when you need to escalate care. So yes, I too love the bladder, even though I'm not a geriatrician and I don't often get to POCUS in my home. So, um, we wanted to make sure we had a lot of time for questions, comments, discussion. I see we've got some Q&A already. Thank you all so much for doing this. So we'll go in order. So the ones I know some of the ones, so I accidentally answered one. Um, so here, okay. So the first one that came in actually was, do you know of any pharmacists trained on POCUS? And I thought that was an incredible question. I needed to hear Daniel's answer. My answer is I don't know of any, but what a cool idea because we have our pharmacists obviously doing anti-coag clinics, but I know that there's some like advanced heart failure clinics and stuff like that with pharmacists. So Daniel, I'm curious if you know of any pharmacists trained in POCUS.
I'm not aware myself, but that is very interesting uh, idea of utilizing more different providers because we definitely have pharmacists here, even at the VA, who follow patients for their heart failure, their for their chronic conditions that could be amenable to POCUS.
Yeah, especially if for any of us, the thing is like, what are you going to do? And you want to start with a finite scope. So those long, the A for across, B the bottom that Daniel was describing, that simple, just wet versus dry lung. I feel like that could be a really great thing. You know, you could do a little study because they've shown RNs can absolutely do that. So I love that one. Okay, so we're going to come back. So, what types of conditions can be diagnosed or monitored? So, Dr. Kim went through a lot of excellent examples there. Again, in my scenario, I've done paracentesis for a medically a hospital at home patient. There was at the kind of like our version of the Ronald McDonald House, you know, for adults, it's like down at the bottom of the hill. So I'd gone down there to do a paracentesis. And then one of my coworkers at Vave actually, her mother was home on home hospice, and she had been she was home from the hospital. They were like, she's probably got a couple of weeks, and it had been over a month, and it was becoming really hard to keep caring for her in the home. And so they were just curious, like a gestalt, you know, how long do you think we have with her? Should we be thinking about more bringing in more care, or is this near the end? Of course, we all know that none of us are great about giving those exact. Yes, you have 2 hours and 22 minutes of life left. However, I was able to, and her mom was super excited to see the whole thing. So I went to her house and we scanned the heart, the lungs, the bladder. She had no B lines, and they said it was heart failure, severe valvular disorder. I didn't have any of her records, but she had no B lines, no pleural effusions, and was making urine. And so with that, I said, I don't feel like there is fulminant uh, imminent death from heart failure that will be happening soon. And so they ended up pursuing getting more assistance, more care, and she was more comfortable, and the family was better able to manage. And she lived about another month. So, okay, so that one, I'm going to say that we answered that live. And then, do you need Wi Fi to use in a universal probe? So, the way that it works is it's the device itself sends the data via a wireless signal. So, you don't need your cell phone to be on Wi Fi. In fact, you can't be on Wi Fi because your cell phone or so Android or iOS, tablet or phone, your smart device is getting the data via wireless from the probe. And so while you're doing that, your Apple might pop up and say, you don't have wireless. And you're like, because I'm getting this data here. So you don't need wireless to use it. It's sending the data that way. To share images later or to sync, get it to the cloud, you would need it. But you only have to do technically every 60 days, you have to log in for security purposes. Okay. What training is required for healthcare providers to effectively use portable ultrasound devices? So I labbed on for the last two. So Daniel, I'm going to kick that one to you. What do you think is kind of minimal training to effectively use portable ultrasound devices?
Yeah, so that's a great question, and I think that's changing as we speak, as more programs, training programs around the country are implementing POCUS as part of the curriculum and residency and fellowships. And I'm training geriatric fellows here in Philadelphia and to get them comfortable with its use. And so I think it all depends on what the focus would be when you're using ultrasound. And for people in the home, really, I think the pillars that I feel like are the most helpful are going to be definitely bladder ultrasound, definitely lung ultrasound, and the jugular venous pulse. And I think if you can do these three modalities, there's going to be really the biggest bang for your buck. And these three modalities are actually quite easy to learn and to become proficient in. And these three modalities are what I focus on training the geriatric fellows at Penn Jefferson and at Temple. And the curriculum that I run currently, I do like a 2-3 hour session in the beginning of the year with them, and then 2 to 3 additional sessions that cover kind of quality assurance, image reviews, and by the end of 3 to 4 sessions, a lot of these geriatric fellows feel confident in using ultrasound as they move forward in their career. But as Renee can probably speak more of, if you're wanting to do like cardiac echoes and measure like valvular regurgitations and those kind of things, that requires a higher level of training. And Renee can speak to more to that.
Yeah, it's all in what you do. And so I always mentally break it down to the three POCUS pillars again: image acquisition, technical, physical skill, image interpretation, that cognitive, and then the clinical integration. You can't hurt someone by ultrasounding them. You can also hit them with it. That will not happen. You can hurt them by making a decision that is incorrect. So I like to tell my learners, I love talking about clinical reasoning. And if all of your data is pointing one way and your POCUS is like way out over there, you're taking all those data, right? So the physical exam, if you have any labs, if you have anything else, so that clinical integration piece, and then making it focused. Don't let perfection be the enemy of good. Just pick one thing and start with one thing. What is your biggest pain point for your facility or your home care or your clinic or whatever? Is it that patients hate you when you send them to the ER for X, Y, and Z? Or is it that you're getting these readmissions, or are you value based, or are you trying figure out what your pain point is, then talk to an expert about what you might be able to target just to start, and then just do a little baby pilot and see what happens. So I think start small, start focused. Um, and then there's one other thing I was going to say, but I rambled on too long. So um, yeah, the POCUS community you will find we all do this because, like, I'm literally in Hawaii. Uh, we do this because we love it and we will preach it like from the rooftops and we want to share and we want to help. Like someday my goal in life is to like have a company where all I do is I do like POCUS and procedures in the home. Like, so we all like people love it and we want to do the best for our patients. And so, any of us in the POCUS community, you can reach out to me with any questions and I will, if I don't know the answer, I almost guarantee I'll know someone who does because I know a lot of POCUS people. So, okay, long-winded answer. Back to, okay, so now we're going to do Olivia. Thank you for the question. This is awesome. Thank you. No, I'm kidding. Daniel's the best. However, so all of our providers cannot have an ultrasound machine. How did you practically operationalize POCUS with regard to how many machines to buy, who to train or hire, and who, when, how are the ultrasounds done at home? So obviously that could be a talk in and of itself. Daniel, do you want to do I've only again done this on my like little like one-offs. I don't have operationalizing experience. Do you have any thoughts on this? Sorry, I kicked the hard ones to you.
Yeah, no, it's I think it's a very great question, and I think it's I guess it's going to depend on everyone's practice and the team members that you have, and um, I think it's going to be important to um, I've known geriatricians who have bought an ultrasound themselves and have taken kind of the liberty of learning it on their own and using it in their home and becoming proficient in that. And I've had patients who are not patients, physicians who attend like the national conferences to gain some proficiency. And then I've had other geriatricians who have colleagues at their hospital who are proficient in ultrasound that have helped kind of guide and teach image acquisition and interpretation. And so I think it really kind of depends on the providers that are there, what kind of POCUS proficient people are already there that could potentially help. And certainly, I think that the biggest challenge is kind of buying into it and kind of diving in and making a purchase of an ultrasound device because I think people are hesitant to do that. But you'll find that once you have the device in your hand and you start using it, that it's easy to use and very very beneficial. So I know it's a very general answer, but I think if you have more specific questions in regards to your specific department, I'm happy to talk to you guys offline and troubleshoot.
I love it. Yeah. So stay focused. It used to be. So one of the studies that one of my students did was like, what are the main barriers just in general internal medicine? And it was like money, machine access, education. So now the machines, you can get them for, if you will be doing a shot, there'll be an email coming out. You can get them for under 3K. And the machines are, so you can get everything's gotten much less expensive. So education ends up being the bigger barrier. Start small, do a pilot, and then work from there is like really so okay. So I'm going to keep rocking because oh my gosh, y'all they put in so many more questions. This is so exciting. So anonymous attendee, their EMS primarily, so they do flight paramedics and nurses performing POCUS routinely. Huge benefits for patients, help us drive treatments in the field, but also helps to inform the most appropriate destination decisions. So I love that concept for triage. Amazing. I have a question about could you discern whether fluid in the bladder is urine or blood, just in cases where the ultrasound will be able to spot a much more severe situation? I gave you all the hard ones, Daniel. So do you want to take that one?
Yeah, so it kind of depends on the in terms of like when you're looking at fluid through ultrasound, fluid will appear black on your screen, and we call that being anechoic. But depending on the kind of the chronicity of the blood that you're seeing and whether it's formed a clot, you can see different shades of gray that could indicate that this is blood. This is not just a simple fluid, and it is more of a complex fluid. And Renee, if you want to answer that to more
No,
detail.
totally. That case, we knew it was a hematoma when we put it on. We could see it, and so the difference is there. So okay, love it. Is it say so? One of what are the biggest barriers? I think we've heard a couple here, right? So like you've got a whole fleet of people. So who gets it and when? Because it might, maybe later on this will be like everyone will have one, but um, how do we? I think the educational component and operationalization. I can't even. Did I say that word right? I'm on vacation mode. Any other thoughts from you, um, Dan, on those biggest barriers?
Yeah, no, I think a lot of physicians who have been practicing for a while, they not surprisingly they still have this kind of reverence for the physical examination, and I think it's hard for a lot of physicians who've been practicing and this is what they've been doing for decades to kind of give that up and try to adopt another modality, and so that's another kind of emotional barrier that I've come across.
Okay, perfect. Thank you. I just answered one via. Oh, hello, Arif Hussein. Um, Arif Hussein is a former WinFocus president. So, y'all, if you're interested in international work, WinFocus, World Interactive Network Focus and Critical Ultrasound, they are, in my mind, I believe that they are the largest international education group focused on point of care ultrasound. Um, so, for instance, like in the international setting, I was over in Malaysia and they were talking about in Borneo, those longhouses, people might never leave their entire lives. So talk about home care. For pregnancies, we know the riskiest day of a woman's life is the day that she will deliver a baby and also to that infant. So the home care is not just in the US, it's everywhere. So do you encourage doing cardiac ultrasound on home visits? I would say, and then I'll kick it to Dan. Um, for me, I think if you were an expert like Daniel, sorry, I'm getting all like distracted by people out in the ocean. Uh, Absolutely. But maybe focus if you're like, I'm going to be sending out a bunch of like minimally trained people or I'm trying to start my program. I probably wouldn't start there because you could just do the IJ. You could just do the lungs. So I'll kick that one to you, Danny.
Yeah, no, I completely agree, Renee. I think cardiac ultrasound is something that I reserve for, it's more of an advanced skill that I think as you become comfortable with bladder, lungs, and IJs, that's something that you can add on to your arsenal. And I think in the home, I think it could be helpful, but really the three modalities that I mentioned are going to be the most helpful. The cardiac ultrasound, I think, will be helpful in if in kind of diagnosing new heart failure in a patient because you can tell if someone has a reduced ejection fraction and things like that. And so, like Renee said, yeah, it's definitely possible, and I think utility is there, but I think the utility for lungs, IJ, and bladder are much higher, and that's something after mastering that can definitely work on cardiac.
Love it. Okay. Justin Johnson asked, would a mobile hotspot suffice for connectivity, sharing images in real time? Like, absolutely. Even just your cell, like your cell will do it. It's just that while I'm actively connected to my probe, the probe is sending the information. So the you disconnect from the probe and then you do whatever. Okay. Let's see. There's so many. This is so exciting. Valentina, so we do have a butterfly device we use with hospital at home in South Florida, not wireless, small device, small but mighty. You guys ever use one of these with paramedics and transmitting very minimal, basically just bladder scope and Dopplers sometimes. Oh, and someone else commented on the ultrasound guided IV insertions. An anonymous person that said, don't forget access. Amazing all the things you can do with the device. Thank you for sharing the information. So yeah, absolutely. So um, this is where I'm going to break out of my like my vape hat. Someone typed in, what do you think makes your device the best? So I will give you the pros, and then I'll tell you. I believe I just want you to use ultrasound. Okay, I would love it if it's with us because I busted my butt to try to make everything. Work with the team. We've all to really try to make it like the most affordable, the most straightforward to use. Like simplicity, simplicity, simplicity. You buy it once, you're done. You never have to pay a subscription. You get the storage, you get a 3-year warranty. There are no other costs. And that took a lot of pushing from our, it was back and forth, because people make money on subscriptions, but we're all subscriptioned out. I'm done with it. And I was like, that's not how medicine works. Doctors don't want to pay more money. We don't want to have to put it into our operational budget every year. We just want to buy something and use it. So that to me is like the single one of our biggest, and then being able to be uniform universal device being able to do deep and superficial, those are the best. But guess what? Butterfly's great. You saw that old school, that 2016, that was a GE. There's a lot of different companies. You need to research and compare them. So I'm cool with that. Okay. How good are AI coaches for improving image acquisition? Let's see. Dan, have you played with any of those?
Actually, I know Bruce. He's one of my colleagues
Uh,
at Penn and
uh,
a mentor. But I have not yet. But it's certainly becoming more available in some devices. I don't have much experience with AI yet, so can't really comment on that.
so I've used them. I've played with them. Um, they're not as intuitive as I thought they would be, but maybe because I already know what I'm thinking. So they're working more on validating them. It's a very hot topic, AI in general. But it's like I tell people, I'm like, look, if the AI is to get cardiac output off of a apical five-chamber view that no one can get, that's not helpful. So yeah. Okay, so I just put in an answer to Elizabeth. Does Vave have an open API? We do not, but we do work with people on APIs. So you can pitch us on your question. Not all POCUS probes are FDA 510 cleared for home use or in ambulances. Any concerns about off-label use? That is so fascinating. That's from Dan Merton. Um, Gosh, I don't think that our FDA says anything about where it's used. I think the limit is in like it has to be a trained provider, and even that is all vague. And the AMA says no one owns ultrasound. So fascinating question. I'm sorry, I can't answer that anymore. But Sean and Jordan, if you wouldn't mind slacking that to me, so when I'm back from vacation, I can research that more. That'd be amazing. Okay, great. A bunch of people have asked about like training. So there's a million different, I love the NephroPocus website. So the hope is to get a live course back at AAHCM at some point in time at the national conference. Dan had done one back in 2022. Obviously, a lot of logistics there. There are so American College of Physicians, Society of Hospital Medicine, the depending on so how about any other additional like home care specific stuff like Dan for that kind of any thoughts on that?
Not, yeah, nothing specific, but I think there's a lot of great free resources on even on YouTube, and so you can simply search on YouTube like how to do bladder ultrasound, how to do lung ultrasound, and you'll find a lot of great tutorials. And so you don't necessarily have to buy a $2,000 course and attend. I mean, if you can, that's great. But if you want to learn the basics and just learn how to simply scan the bladder or the lungs or the IJ, I think, a lot of the free tutorials online are great and are a good start off place.
So question about from Costa Rica, email me and I'll hook you up with my friend down there. He's a doc, Jose. Can try to get you some resources. Wearable patches from Dr. Scott Grogan. So fascinating. I do think like maybe a t-shirt that does heart failure or something. The future for long patient transports. Yeah, absolutely. I mean, I think there's so much we can do to keep patients in the home. Mohammed had a question about heating. We have some of that info on our website, and then I'm happy to chat with you separately. I'm just trying to crank through the laws. Gold standard training programs, just a ton. Okay, RNs able to use POCUS, absolutely. I like to say that procedures are the gateway drug of POCUS, doing procedures. So your IV access, et cetera. Bladder, the basic, there was a study where they did long, wet versus dry IVC. IVC didn't perform super well. The long, wet versus dry was good. And also that IJ is so easy. So, okay, centrally view ultrasounds in real time. So they does not have real time uh, like teleguidance yet. We're working on it, but you can literally share them immediately. So like disconnect the probe, share them, and get the feedback right then and there. So totally easy. How do you store images and videos? You can click to store an image or the videos. You can have it on your device, or there's an optional cloud that's free and included with it. Again, the whole point is to like buy something and never have to pay more money. So, okay, I think I'm so sorry if I missed any of these, but I think we cranked through them and it's exactly 11. So really appreciate, oh, what size does baby need to use portable ultrasound? Never use EMO or never use a color Doppler on a baby of any size. And maybe talk to an OB person for that one because I'm just a basic old internist. And then is POCUS relevant in the discussion evolving topic of hospital at home? Obviously, we think so because we are here. Um, so yes, love it. Oh, Dr. Cuneo is our partner. Okay, perfect. So looking to kick off POCUS with educational partners. Goosey, Global Ultrasound Institute. They're phenomenal. They do a ton of different POCUS training. I should have thought of them earlier. Yeah, so I think Goosey might be who will our Goosey friends here. I think Dr. Mena Ramos and Kevin Burton are on here. So okay. Thank you all so much for your time and effort. I'm going back to vacation mode. So
Thank you.
all right. Thank you, Dr. Kim.
Thank you, Renee.